Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD Podcast. Tro, we've done it again, man.
Yeah, we got somebody who smokes this, man. Is just absolutely brilliant guy. I've been following him on Twitter for a long time. Very provocative and interesting commentary. And I knew right away we had to get him on the podcast. So very, very happy. We have Dr. Tarek Arab. He is an obstetrician, and he started his med school training in the King Abdulaziz Medical School in Saudi Arabia. He did his residency in the University of Ottawa and then later in Manitoba. He did his ultrasound fellowship in the University of Ottawa. And he's an absolute powerhouse when it comes to understanding the link of insulin resistance and PCOS, obesity, and he has a particular interest in GYN cancers. And he's been in private practice and dual private practice in academia since 2015, where he's a faculty member at the University of Jeddah in Saudi Arabia. So thank you, Tarek. It is so nice to have you here. I absolutely love interacting with you on Twitter. This is going to be awesome.
Thank you very much for the invitation. And in terms of brilliant, don't confuse me with you. You're the guy that was getting the 95th percentile. I was the guy that was barely making the centiles.
Listen,
and that isn't false modesty, believe me.
Look, I'm a very big fan of yours. Your style of commentary, the way you cut through the BS, and certainly you've made some very interesting statements that caught my attention and Brian's attention. So we're happy to have you here, another doctor on the front lines. So how did you get interested in nutrition? I want to know, because they don't really teach us this. You know, I don't know if you got much exposure in your training, but how did you come to, wait a second, you know, this is something I should be paying attention to?
Well, essentially, you know, I'm one of those guys that got into med school through more hard work than anything else. You know, I'm not a natural scientist. If life had gone differently, I would have done history at university, and I would be somewhere very different now. So because of that, I've always been focused on understanding what I'm doing, just because I don't have a great memory. Now, along came second year biochemistry at med school, and something caught my eye. And that was, when you're talking about cholesterol synthesis in the body, you know, with all our abject terror of hypercholesterolemia and so forth, we're telling people, okay, we need you to cut your fat. We need to stop you eating too much seafood. You need to cut down the eggs. You need to cut down the meat. You need to go high carb in order to cut your cholesterol and your risk of heart disease. So why is it that the hormone that stimulates cholesterol synthesis in the body is insulin, which is not stimulated by seafood and eggs and meat, right? So I began to think about this in the background. At the same time, I was, you know, embarking on a little health journey of my own, you know, going to the gym, reading all the, you know, muscle and fitness and all the other magazines in terms of how to build muscle and so forth. And again, that interest in nutrition began because, you know, when you're talking about protein and muscle growth and protein synthesis and so forth, you've got to actually understand the basics behind what's going on, right? As I went through medical school, you know, people would ask me, I'm fat, I want to lose weight, how do you suggest I do it, and so forth. So then I realized, okay, I've got a gap in my knowledge, I need to fill it. Started reading. First off, I read The Zone Diet by Barry Sears. Friend of mine had severe PCOS, and this was my first introduction to PCOS. I suggested she go on the Zone Diet. She lost 31 kilograms in 6 weeks. And she was in shock. This is a woman who, you know, had the classic, what we call Stein-Leventhal PCO appearance. So she was morbidly obese, and she had hirsutism, and she was pre-diabetic. Poor girl had periods every 7 months, which were severely heavy when they came because of all that anovulation. So she was shocked, and of course not as shocked as I was, but obviously, being a med student, you have to pretend that, oh no, I was totally expecting this. So I read the Zone Diet, experimented with it myself at the time, didn't find it was working for me. So then I ended up reading Protein Power by the Eads and experimented with that, found it worked really well. Now at the time, I was relatively healthy, good BMI and so forth. Went through a 6-month period of time where had some mental health issues come along, and unfortunately took them out on myself by eating. And I won't advertise for the fast food company that got me to my rather better fed status after that. But my interest in nutrition continued, especially when I would begin to experiment with myself and notice that, yes, calories in, calories out might work in the short term, doesn't work in the long term, reading a bit of exercise physiology and so forth. And then, given that I'm a natural contrarian, I was getting the message in the clinical years of med school that, okay, we need to cut our fat and we need to raise our carbs and we need to watch the protein because protein is bad for your kidneys and so forth. And I'm the kind of guy that if I see a crowd running in one direction, I will look to the other direction to see what's going on. I won't just follow. So as a result, with the intervening years, my interest in nutrition just increased. And especially when it became personal, where I started trying to shift the extra pounds that I had put on, as a result of that rather dark period of time. So essentially it was from there, fast forward, into the bodybuilding years where I'm going to the gym and working out hard and trying to follow a bodybuilding diet, not seeing the physical effects I wanted because I didn't know about insulin resistance at the time. Then ended up in paleo, experimented on that on myself, experimented on keto because that was the next step that came up after that. Recently tried carnivore, interesting results. So, it's basically for me been a work in progress because I want to be able to advise patients, but I want to know that I fine-tuned everything myself so that I can genuinely, show them the kind of empathy that they may have been lacking in their efforts in other areas. So, the only thing that I haven't tried, which I have no intention of trying, is a gastric sleeve, obviously. Even in that direction, I find that the more you open your eyes and sort of broaden your mind, the more you learn. My initial skepticism, say, towards gastric sleeves is kind of receded a little bit only because I didn't realize what I had been seeing in practice around here in terms of what happens at the patient level care is not necessarily the optimal model. So this is basically where I'm at. And the more I read about, nutrition, the exploding science and so forth, the more I am, I would say that I'm really upset by the idea that in a profession that claims to deal with root causes and aims to be about health and not just, manage decline or management of chronic illness, we're not taught anything about this. At med school, when I was at med school, we were taught literally nothing on nutrition. And from what I can see, that has not changed at all. And I think that's we're missing a really big trick given the amount of manipulation we can do in terms of at least improving quality of life in a lot of people and maybe even resolving certain issues in others.
And I want to bring up, Brian, I don't know how you feel about this. I want to start off straight with the controversy. I think one of the biggest controversies when it comes to nutrition particularly has to do with cancer. Okay. The American Cancer Society says avoid meat, avoid processed meat, limit sugar, focus on whole grains, focus on, starches. Okay. So this right off the bat is a bias against low carb approaches and ketogenic approaches. So this is the American Cancer Society stance. And they have reasons for it, and I won't go into it, but largely based on epidemiologic data. But when you look at the epidemiologic data for cervical cancer, uterine cancer, breast cancer, the relationship with hyperinsulinemia, hyperglycemia, and even insulin-mimic drugs, right? Drugs that increase insulin. There is incredible correlation to the point where even in America right now, there's a very large phase 3 study that I think is nearing completion that's looking at metformin in breast cancer prevention, right? So can you help me understand, because from my viewpoint, I think, okay, wait a second. The American Cancer Society is saying basically eat more carbs and starches, avoid meat and, and avoid meat and eggs and dairy. And then on the other hand, there's all this data showing that high blood sugar, high insulin is at the least associated in a negative way with breast cancer, uterine cancer, cervical cancer. Help me make sense of this, because I think I'm missing something.
Well, if we look, obviously, the British Cancer Societies did come up with a statement a while back about how obesity alone is linked with 10 or 12 different cancers, right? So I infer from that it's mostly not just obesity as much as the inflammatory environment and the underlying insulin resistance. Now, as we all know, epidemiological studies can prove whatever you want them to prove, depending on how you pose the question and how you look at the issues, right? Now, obviously, I can't speak to why the American Cancer Society would take that stand. Obviously, I will say that I'm sure their primary directive is to ensure that they keep cancer patients who are particularly vulnerable population away from harm. And if you look at, say, the WHO talking about meat as a class 3 carcinogen, especially in the colorectal cancer population and other cancers, it is understandable that they would take that stance against meat. However, I reviewed this subject for a blog I wrote for Spectator Health recently. And what I came across was the fact that a lot of the studies that have supposedly, given credence to the idea that meat is a carcinogen, haven't always distinguished between processed meat and unprocessed meat. Some argue it's the nitrosamines in meat that makes them carcinogenic, but there are other studies looking at vegetable nitrosamine content that have found that certain vegetables contain more nitrosamines than unprocessed meat. So, evidently that is not the whole story. I think within the medical profession, there has been an idea from the beginning, from the days of Ansel Keys and all the subsequent jiggery-pokery that happened, that basically carbs good, protein equivalent, saturated fat bad. And the epidemiological studies that came out subsequently lent credence to that. Now, obviously, I'm not going to go into the controversies in terms of, were these studies influenced and all the rest of it. But I think that this would probably explain the bias that a lot of people in the cancer community have. Because if you take, an epidemiological study, cancer patients do a food questionnaire, which we know is so inaccurate that they should probably be retired as a means of research. And then you ask patients, and then you find, patients, because they've been told for years, meat is bad for you, eggs are bad for you, saturated fat is bad for you, they are going to recall eating those foods more than they're going to recall other foods, which may or may not be injurious. As a result, you've already got the recall bias being introduced on top of the existing recall bias, right? So I think that is part of the problem. The other part of the problem is, remember, medicine put its eggs in one basket. Cholesterol hypothesis, carbs are good for you. Carbs should be 60% of your diet. Saturated fat should be less than 10%. Protein should be barely adequate, okay? Because, too much protein is going to destroy your kidneys and give you cancer. They're not going to back down from that because it has percolated, cardiology, obs and gyn, internal medicine, pediatrics, endocrinology, cancer care. So when studies are coming up, for example, you mentioned breast cancer. There was a study a while back looking at breast cancer survivors, and they found that women with a lower overall carb intake appeared to have improved survival. Now, again, correlation, not causation. I'm not suggesting by any means that this proves anything other than something that needs to be studied further. If you look at the ovarian cancer population, we know, and again, I didn't know this until I read it recently, that obesity is an independent factor for adverse outcome, as in worse outcomes in the ovarian cancer population. When you consider that ovarian cancer cells are rich in insulin receptors, you start to think, is there a biochemical connection here that we've missed? So I think that when you drill down to it, we're dealing more with good intentions, a bit of politics, but also the fact that, at the time we're living where there is so much, not just accountability, but blame being passed around. Anyone suggesting that perhaps we should relook into the factor could be accused of putting cancer patients at risk. And nobody is going to, in any good sense, propose a study which questions that, especially if you've got so many people saying that, oh, you're going to put them at risk. And what happens if we find that you're wrong and that this emphasis on lower carbs and higher protein and higher fat is actually translating into worse outcomes? They're not going to give those people the benefit of the doubt in terms of, okay, was this correlative? Was it causative? Was it confounded, et cetera, that they would give other studies. So, I think it's going to take a seismic shift in how they look at things. And I think the answer to this will probably lie more in basic science research. The more we discover the connection between insulin resistance, receptors on different cancer cells, mouse studies, cell studies and so forth in the lab, which will give enough weight to the idea that perhaps at a macro level, we really need to start looking at not necessarily interventional trials, as much as, start small retrospective series. Let's look at the potential connection between carbs, insulin resistance, as measured accurately, and potential outcome, and take it from there.
I've seen so much data pointing to insulin resistance and breast cancer and uterine cancer being just the odds ratios are so high. I think it's like at this point, we just can't ignore it anymore. And just for the listener, just what we're talking about basically is when you look at these association data, the higher the odds ratio, the more that signal may have an actual clinical a meaningful and clinical impact. So so much so that we're even giving metformin as a drug to prevent breast cancer, and we're testing it out. There's a lot of oncologists I know who already give all of their breast cancer patients who are obese and have metabolic syndrome, they give them metformin, right? And that's off-label, certainly. It's not a main practice. It's not recommended standard practice, but a lot of oncologists are doing it. Certainly, many oncologists are doing equally, questionable approaches. I know other oncologists restrict protein, in cancer patients as a mean for prevention. So, but it's come to the point where we're even going to test it. We're testing it in large-scale trials. We're literally giving metformin. Why wouldn't we just cut out the sugar and the processed carbs? That's what the metformin is addressing. Right.
Well, and also fibromyalgia, they're using metformin for that. Lowering insulin levels seems to help with pain levels and inflammation and things like that also. But, I think maybe looking at a study of women with PCOS and following them long term, since we know they're both insulin resistant, right? Because, one thing is you can be obese and be metabolically healthy. We've seen it, Tro, right? We see people that are just huge that can just keep putting fat into their fat stores and their insulin and triglycerides and markers may be. So it would be interesting to see if those people who aren't insulin resistant are at increased risk of cancers, even though they're obese, right?
Yeah, absolutely. I agree. So what's the, is there a harm? I'm just curious in breast cancer or is there a harm not to say it's for breast cancer prevention, but is there a harm in considering a real food, low carb diet? Is there a harm? Because some patient advocates, cancer patient advocates would say, we should not even talk about nutrition when it comes to cancer. But, we've had many patients come to me say, we want to do this diet for cancer. And I say, well, we don't know if it's going to work for cancer, but you can do it for metabolic syndrome, insulin resistance, obesity. And if that happens to help cancer or PCOS, like Brian said, or fibromyalgia, then you get 2 wins, but we do not know. We don't know the signal. So, but is there a harm to say that, because many patient advocates have attacked me and Brian about, that statement, that we should do a diet.
Study. Yeah, no, there's a fascinating study going on now at the University, I think it's of South Carolina, and they've taken patients with metastatic breast cancer and they've offered them, a pathway whereby they can start a ketogenic diet and be monitored closely. They're having imaging every 3 months, and this trial is still ongoing. I think it's just a prospective cohort study. 20 patients, if I'm not mistaken, have been enrolled. And what they're finding is that these women are experiencing shrinkage of their metastatic tumors. Now, to be clear, no one is claiming that this is a cure. No one is saying it's going to cure anybody. The emphasis was looking at, is there a quality of life improvement on the ketogenic diet? So, I would not use that one study as the basis to conclude something for the whole population at large. But clearly at a macro level for breast cancer, for metastatic breast cancer, there appears to be evidence of little harm in terms of, we have not observed growth of the tumors. Now, I think, again, the answer here lies in what happens in understanding what's happening at the basic science level. We know that cancer cells, via the Warburg hypothesis, have got impaired metabolism. They're not metabolizing, they're preferentially metabolizing glucose in terms of metabolic fuel. When you introduce ketones into that environment, you are then compromising the ability of that cancer cell to then adequately fuel itself and then to grow and then to multiply. And this has been proved in the lab in various backgrounds, but also with various cancer cells. So for example, they've looked at pancreatic cancer. They looked at glioblastoma multiforme. They haven't actually looked at gynecological cancer. That's something I'm hoping to do if by some miracle I get into a gyne-onc program that supports me in doing that kind of research. But they've looked at it at multiple levels. And, with the exception of a mouse study that was done at a pancreatic level, that came out, I think, in Nature 2 years ago, which was heralded as proof in the media that the ketogenic diet can cause metastasis of cancer because they found that these cancer cells were actually able to use ketones to grow. The majority of the publications thus far indicate that ketone bodies are injurious to cancer cells, right? You've got multiple case series, especially with the neurocancers, some in the leukemia cancers, but specifically with glioblastoma multiforme, where you've had patients reporting improved symptomatology in terms of, headaches and visual symptoms. You've had some patients that may have actually lived a little longer than they would have done otherwise. Again, it's not clear, so I'm not suggesting that this was, causative more than it was correlative, but the idea that we don't have sufficient data to at least consider seriously the exploration in trials for patients who have been counseled that we are still in early days, we don't know, is not accurate, because thus far we do not have evidence that going low carb or ketogenic in cancer patients is going to be harmful to them, whether via quality of life. We've looked at that in the gynecological cancer population. We've looked at it in other cancers. The majority of patients starting a ketogenic diet will either experience an improvement in quality of life or will not have an improvement in quality of life. But there is nothing to say that quality of life will get worse. In terms of cancer growth, no study's been done that shows that ketone bodies are correlated with the growth of cancer cells, right? And as I said, that the breast cancer study that is ongoing suggests that for the breast cancer population, being ketogenic may be useful. Okay, so again, all preliminary, small study. I just want to emphasize this. So, definitely, if the question is, do we have high quality studies in the cancer population right now to commend a ketogenic diet for, whether the idea is to improve quality of life or as an adjuvant to treatment? No, we do not. But the reason we don't have it is because nobody's funding those studies, and thus they're not being done. We all know that, absence of evidence can either mean that 20 RCTs were done, which showed no evidence of benefit or evidence of harm, or that not a single randomized controlled trial was done because nobody wanted to fund it. And I think that is a major problem we have. So, I think things are changing. You've got a lot of patient advocates who are now, calling for nutritional manipulation. A study was done 2 years back looking at the ketogenic diet in ovarian cancer and endometrial cancer patients. They found that they experienced, more weight loss, decreased abdominal obesity, improvement in LDL and other biochemical biochemical markers, none of which are going to correlate to a difference potentially in outcome when it comes to that cancer. But at the very least, people are now looking in that direction, which I think is a huge step forward, given that for whatever reason, we seem to divide cancer perspectives into two directions. One direction is chemo good, radio good, traditional therapy good. The other direction being, oh, that's all poisoning and killing you. We should all go down the crystal route and, vegan diet and all the rest of it. And I think a healthy middle ground exists where we can acknowledge that, all the research we have for chemo, for radio, for immunotherapy is robust enough for us all to agree that it is definitely representative of optimal cancer treatment, but that we can try to target the what I call the hormonal milieu in the body, where in which the cancer grew in the first place, through judicious nutritional manipulation that will not affect primary treatment. We know the ketogenic diet can act as a chemosensitizer and a radiosensitizer in certain cancers. We know it can reduce the side effects of chemo and radio in certain cancers. So we've already got evidence of potential benefit. So why not take it to the next step again, provided that patients are adequately counseled and they're given the facts and they're given the uncertainty, and we leave it up to the patients. And we do it in such a way that we can't be accused of manipulating the fears of patients who are desperate for a cure.
Yeah, and I think it's important that we say this is for an adjunctive treatment with the standard of care, right?
Awesome.
Because my wife's best friend, by the time they found out, she had metastatic breast cancer everywhere. And she went keto, and because they were asking me what I thought, and I said, look, if it were me, this is what I would do. I can't give you medical advice. You're not my patient, but this is what I would do. And her husband jumped all in. And the amazing thing is she went through chemotherapy, and she would go see the doctor. My wife would go up and take care of her, and she'd be sick that day. The next day she'd wake up fine and then live her life. And then she'd go on Monday again for chemo. And the doctor said, man, I feel so bad because I know you finally started getting better on Sunday, and now I'm doing it to you again. And she goes, no, I felt fine the next day. And the doctor laughed because he thought she was joking, and she was on a really strict ketogenic diet. And so probably she was shunting that treatment to the bad cells, and her good cells were running on ketones, and she was feeling better. She ended up dying of breast cancer, so clearly wasn't a cure, and she wasn't really strict on her keto after the treatment. But going through treatment, I guarantee you that helped her. I mean, she went through it with flying colors. But that's just an anecdotal case. But I'm saying there are people like that when you say, okay, I'm doing the standard of care. How do I make it the best I can?
Ryan, can I ask you a question? Mm-hmm. So if they're eating a standard diet or a high carb diet, and they get the nausea and the pain and the suffering from doing chemotherapy, and they essentially fast for 3 days, they are forced to have a keto flu every single time they fast because their fat oxidation isn't high and their carb oxidation is through the roof before getting chemotherapy. It seems quite plausible that if you get somebody fat adapted before chemotherapy, it may improve their quality of life, right? They may be able to fast with ease. So I agree with Dr. Arab and Tarek. I agree with you because we should see what happens. And there are some studies that have been done looking at the quality of life that have shown pretty good outcomes on patients with a low carb diet. So Brian, I think exactly what you're talking about. I'm very sorry about your wife's friend, but it truly could be that diet was helping her quality of life. I don't know. There's data,
the bigger issue really, Tro, is the oncologist is concerned about weight loss, so they're trying to keep weight on people. So when you mention fasting, they flip out because they're thinking, man, you're going to make my patient weak to go through chemo, and the chemo is going to kill them because they're weak. But if you're doing a high-fat ketogenic diet, that changes the equation because you're really trying to get healthy fats into the person, cutting down the sugar, which is, we're talking about insulin-like growth factor and all these other things that can stimulate cancer growth. So I think, you're looking at the big picture and you go, okay, what's our best management?
Yeah. So, what do you think? I think at the least there's a quality of life. There's some data, Dr. Arab, on the quality of life that's been looked at, and it looks pretty favorable to me. It certainly doesn't say that the ketogenic is some terrible, a ketogenic diet is is going to ruin the quality of life of some of these patients.
No, I totally agree. I mean, for multiple reasons, the way I look at death is a little different to most people, right? Now, how I look at death is, in my religion, in Islam, what we believe is that death, the moment of death is written for you, but it's how you get there that is not. Now, some would argue this would mean, oh, you're not, this takes away the concept of accountability for, say, malpractice or whatever. No, not at all. It's just the idea that if you know that your moment of death has already been chosen for you, you can focus on living, right? And what I used to always tell cancer patients whenever, during my gyne-onc rotation as a resident and after when I came back to Saudi and was working with an oncologist, I used to say, look, cancer is one of the worst diagnoses that you're ever going to get in your life, right? From a perception point of view. But I would always tell them, look, you can choose how you handle the news. You can either be a cancer patient, meaning you're waiting to die, or you can be a patient with cancer, meaning waiting to live. And by waiting, I mean getting through your treatment and then getting on with life. And I think that quality of life is something that we really should focus on perhaps a little bit more than, say, all-cause survival or cure even. And what I mean by that is, none of us, no matter how healthy we are, know how long we have left, right? Tomorrow, a 21-year-old can die in their sleep for causes we can't identify. The day after that, a 98-year-old woman can be admitted to hospital for COVID-19, come out in 3 months, and is doing fine, right? So I really think that we need to focus in a two-headed manner. Let the oncologists focus on cure. I want everyone to be cured of cancer. I don't want anyone to die of cancer or to be afflicted with cancer. But at the same time, let's try to make sure that whatever time they have left is quality time. Now, I understand where people are coming from when they say, don't bother cancer patients. If she wants to eat ice cream and she wants to eat cookies and she wants to eat biscuits, she's going through hell, let her do it. And I always say that at the end of the day, there's no compulsion. What the cancer patient wants, the cancer patient gets, and that's the end of that. But having said that, as you said, Tro, if we can optimize them, so that when they go through chemo, they're not having both the side effects of chemo and a semi-keto flu, then I really think that, that would convince patients as well that, we're trying to make the experience as bearable as possible by setting you up in such a way that we're going to give you the habits you can continue to utilize long after your treatment is over, and hopefully you're cured, or at least your functional status is good enough that you can live your life. And, especially in, say, breast cancer, stage 4 today is not stage 4 5 years ago or 10 years ago. There are women who are living today with stage 4 breast cancer who have a very good quality of life, for example, right? What I, as a doctor and a human being, want for them is the best quality of life that they can enjoy. We may find in 20 years' time that there was nothing in the promise that ketone bodies showed at the cellular molecular level. We may find it made no difference. We may find it may have made a difference. And I really think the time is ripe, especially with the epidemic of obesity, of metabolic disease, and the translation of that into cancer. We've really, we cannot prevaricate any longer. But unfortunately, there's so much politics.
Can we harp on this right now? Because this is the most important thing. Obesity associated with worse outcomes in breast cancer and uterine cancer. Diabetes and ovarian cancer. Diabetes associated with worse outcomes in, uterine, breast, ovarian cancer, right? Okay. And weight loss is associated with decreased recurrence. Right?
Oh, yeah, and decreased risk. If you do a gastric sleeve on a morbidly obese lady who goes on to develop endometrial cancer, you're cutting recurrence by like 50%. That is huge. Yeah. So, we definitely have to, we cannot do what we've been doing where we say, right, we're focusing on the cancer and we can't deal with the obesity now. Now is not the time kind of thing. No, we need to think of it biochemically, metabolically, and then at the level of what we're seeing effectively.
Yeah, and I think, and you raise another important point, and this is my area too, I like to look at a lot, is faith and positive attitude, right? So I was just having a great conversation yesterday with Chris Cornell, who is a cancer survivor, and I said, he loves every sunrise, every sunset, every day. He appreciates things to a degree that we just can't appreciate it. And I think people who have a positive attitude, we know that. I mean, I know for a fact, you drop your insulin level, your sugars get better, when you cut down on your stress hormone. So a lot of us, we talk about the Mediterranean diet, but it's really the Mediterranean lifestyle where people just wake up and go, oh yeah, I'm not working today. It's too windy, whatever. So just having that attitude in life, I think helps a lot of people. A lot of people are just going through life offended and upset and, on cortisol, driving their life. And so I think that's part of it is when you get step back and go, okay, what pieces of this puzzle can we intervene on to help that person?
Yeah, no, I definitely agree. I mean, and just to emphasize, that we're not suggesting everyone needs to have a faith of any kind, right? I do think that faith is a very it is a term that should remain broad. Whether you believe in a God, whether you believe in a higher conscience, whether you believe in the spirit of humanity or nature, whatever you choose to believe in, I think that belief should be respected, should be upheld. And if it's a belief that helps you to cope with the slings and arrows that life throws at you, I say all the power to you, because I totally agree. I think that we underestimate the impact that the mind has on the body. And I mean, I can tell you from a personal point of view, I had never realized how much stress and my mindset affects me, till I went through keto 6 months, a year, didn't notice any changes on my physical body whatsoever. And I'm thinking, okay, I've done everything right. I've eaten what I should eat. I've worked out, etc. And then I realized, stress, if it's affecting me without a chronic disease, I mean, I'm asthmatic, but that's nothing compared to what some people have, right? If it's affecting me, what on earth is it doing to people with life-changing injuries? Lord forbid, a cancer diagnosis. I mean, we really have to start viewing mind and body as one. It's good that we're now saying, mental health is given the same parity as physical health. That's great. I look forward to a day where we just call it health. And whether it's because you've got chronic depression or whether it's because you've got cardiomyopathy, you're treated the same way with the same level of urgency and the same level of empathy and compassion. Because I really think the mind is neglected. The East have survived for thousands of years with a deep sense of mind-body connection. This is not an accident. We can't say, oh, that was all coincidental and correlative. And, we discovered evidence-based medicine 80 years ago, and that's how we're going to look at things. No way. I mean, there's a time for this, and I think, and a time for that. And why they can't live harmoniously, on the same plane as the other side of the same coin, I've never understood, to be honest.
Well, you're preaching to the choir here. We know even if you go to evidence-based medicine, look at the evidence. Stress is a coronary artery disease risk factor. Stress is a cause of sudden cardiac arrest. Literally, stress-induced, you mentioned cardiomyopathy, whether you're dealing with the heart or the mind. Stress-induced cardiomyopathy is literally a phenomenon where intense stress literally leads to ballooning of the heart. Okay, literally leads to ballooning of the heart. So if you look at any medical issue, fibromyalgia, diabetes, cancer, okay, it doesn't matter. Mental health, the worse the mental health, the worse the disease.
Well, and they just, and that other study, just having a dog, you live longer, right? Right, because you're out with the dog and then they're happy to see you, no matter how much of a jerk you are. They're always stoked when you come home. So I think having something that you love and that kind of thing, and I think that's the other side of the coin with some of the social distancing that we're seeing and not having that human connection. I'm seeing an increase of depression, anxiety, stress, drug use, alcohol abuse, spousal abuse. And, we have to look at the risks and benefits of every treatment we have. And last night I was watching TV and these ads come on for these drugs coming out and they go, oh, it could cause sudden death, blindness, kidney disease, but your skin will look great, right? I mean, when you start looking at the side effects of some of the things we do, we think, wow, what are we doing?
Yeah. What say you?
Again, I totally agree.
Yeah.
We're going to find something we disagree on. This isn't looking good.
Yeah.
Yeah. Well, Tro and I could usually disagree on something, but I love your perspective on life. Say, hey, look, let's support our patients as best we can going through what they're going through. And I think, like you're saying, compassion, having a belief, like if you believe in flowers running whatever it is, like having something that you love to do. And I'm always surprised at how many people just don't have that outside interest. They're just, especially as docs, because we're working all the time. It's like, I sleep on my downtime, but But I think a lot of us are starting to realize, that we're better doctors when we have other outlets or, things that we do to keep us focused or give us meaning in life. Because, again, look, our career is one of the highest suicide rates, right? Because, we go in to save the world, and we realize we're not saving the world. We're just throwing more drugs at the problem instead of trying to fix the root cause, like as you're saying.
No, but I agree with you. I mean, we are stressed. I mean, I was lucky enough when I did my ultrasound fellowship. I had a year without on-call, without surgery. I had time. I would, go into work at 8:30 in the morning, come back at like 4:35. I would bike there and bike back, except in the winter months, of course. I had so much time to read, and I went crazy. I read politics and history, tried a bit of philosophy, but it looked better on the desk than it did with the book actually open. Read a bit of nutrition, and I just thought to myself, oh my God, I have been divorced from the real world, okay, for all those years with, medical school, residency, exams, and so forth. And it certainly informed the way that I look at things. And I just think it's really sad that our profession is so, all encompassing. Now, if we were spending all day and all night, reading the journals, reading the textbooks, everything focused on patient care, I could accept that sort of silo mindset that we have to adopt. But let's be honest, there's so much administration and, extra non-clinical activities we have to partake in and so forth, that I can understand that, when people leave the hospital 8:39 in the morning, they've got a grant proposal to write and they've got a meeting in the morning. It's like, okay, I don't have time for an interest. And like you said, I need to go sleep. But I think I guess it's a function of whichever system you're in. Not everybody has the flexibility, if you're in private practice, to say, take time out. One of my teachers when I was training used to tell me, he's in private practice. Wednesday morning he'll come to clinic. Wednesday afternoon, it's only for the family. They'll go to, go out with his wife, see his kids or whatever. But not everybody has that flexibility, unfortunately. And, as a group, I think we've been so focused early on, in terms of got to get that test done, get that mark, get into undergrad, get into med school, get into residency, get into fellowship. That we really haven't given ourselves the opportunity to, smell the roses, look at the sunset and so forth. But I'm sure it probably differs from country to country because, we certainly have a little bit more free time over here than I can appreciate, occurs in the US, for example. But still, I think as a group, we definitely need to look outside the hospital window sometimes, but unfortunately, we may not always get that opportunity.
Yeah, and I think, the one thing I remember going through residency or med school, you kind of, you look at all the different specialties, you go, okay, I identify, man, when I did OB-GYN, I was like, their grand rounds, seriously, were the most venomous thing I've ever seen. These guys would scream, and it was like MMA before MMA was invented. Like these guys were just fighting, and it was incredible, the disrespect. And, I think everyone was tired and grumpy, and I was like, man, I'm not going into this field. I just right there sat there and go, there's no way I would do this because and they're probably all sleep deprived and stressed. And the big controversy back then, that's how old I am, is like when you do a hysterectomy, do you take both ovaries or one? And these guys would have screaming matches. If you take out both ovaries, you're killing the woman. If you leave it, then you're causing, ovarian cancer down the road. And so, these questions, but anyone who had an opposing view, they just screamed and cussed at each other, and it was just really, really nasty. So you start realizing, man, that's not good for you to be in that kind of state where you're not saying, hey, teach me why you believe what you believe, and let me teach you what I believe, and see, maybe we learn something from each other.
I think the problem with med school, and this is one thing I realized, it's a very romantic idea that it doesn't matter where you go to med school, as long as you work hard, you'll be a success. Well, you know what? When I was at med school, some of the most unpleasant people were the orthopedic surgeons. I now love orthopedic surgery because I've had a chance to be exposed to it in the right way. Some of the most pleasant people I'd met were gynecologists. Unfortunately, same department 20 years later, very unpleasant people. I wasn't exposed to, say, cardiac surgery at all. When I went and saw it, I loved it, but not enough to go into it. I mean, it takes a bit more patience than I have. I think it really depends on the experience. I mean, the OBGYN exposure I had, now I was lucky. I entered med school knowing I wanted to be an OBGYN. I did some work experience as a 17-year-old with the man that delivered me all those years ago, and I just loved it. So when I went through it, I went through a very helpful department who encouraged me because they saw I was interested. But then when I started my initial residency here in Saudi Arabia before leaving for Canada, I remember looking at the department thinking, you know what, had I come here as a med student, I would never have chosen this field because, they didn't give them the opportunity to really get stuck in. And like you said, they were very antagonistic. There is a very strong blame culture over here in my specialty, which is enough to turn anybody off. So yeah, unfortunately, it really comes down to the people that are there who are actually educating you. The surgical department where I was, I remember we did our first rotation. 80% of us failed the exam, and the surgeons seemed to think this was a badge of honor for them. We failed 80% of you. Job well done. Well, how is that going to encourage me to go into gen surge if that is how, if this is the result of my first treatment? No. It's med school is an entire different topic all by itself.
I think different personalities go to different places, right? Us internal medicine are long-suffering people, and the surgeon wants to fix a problem, get the heck out of there, and go see someone else about the follow-up. And so, with ER docs, I just always gravitated towards those guys because they were fast living and they had fun, but they got life because they deal with life and death every day, right? So they're calm and cool and they handle the situation, and so I think it's just it's kind of interesting how we kind of gravitate towards a certain area of medicine. And I think it's so great. Some of my and what I find really in private practice is my male gynecologists, OB-GYNs, they're very approachable, very cool because they're looking for business too. Like a lot of females say, no, I'm not going to a male doctor. So there's still a lot of that going on. So I can call them and say, hey, can you get this patient today? She's bleeding. Yep, no problem. Some of the female doctors will say, I'll see her in 2 weeks. Like 2 weeks. She's bleeding right now. So, that's kind of the cool thing. Have you experienced that as far as like people are because you're male, it's unusual, or once they know you, it's not a big deal?
Well, it's interesting over here. I mean, I can tell you at all levels. When I started as a junior resident here, I started in a hospital that is primarily for members of a subdivision of the Army, the National Guard. So these are very traditional people, okay? And so we're talking about ladies who cover their faces, who, will not want to go to a male doctor. The interesting thing I found was 90% of the women who would refuse to see me or allow me to examine them in the labor room or in the clinic would agree once I had been kind enough to explain to them what I was doing. And then I realized the problem was these women were used to doctors examining them without explaining what they were doing. And from her point of view, if the female doctor is doing that to me, what the hell is the male doctor going to do to me, right? So when I found if you explain to them, 90% of them would be more than happy to let you examine them because they understood you were doing it for a professional reason and it wasn't, for some nefarious reason. At a senior level, as an attending now, obviously in the private sector, it's a little different because she won't come to you unless she's willing to see you as a male doctor. But the majority of the really busy doctors in the private sector over here in Saudi Arabia are male doctors. I don't know why that is. I've asked some patients because I love to gossip with the patients about various issues, and some of them have told me, no, some of us will go to a male doctor because we find some of the women are a little rougher when they examine. Some of them aren't as empathetic. Some of them have told me bluntly. I remember one time, and this really, it made me laugh, and I shouldn't have because it was probably a little unprofessional of me. But I remember one day when I was a junior resident here in Saudi Arabia, a patient came in, very traditional woman, covered her face, everything, husband, very religious man. So I thought, okay, great. I'm not going to have anything to do today for this patient because she's going to refuse to see me. My colleague went into the room and comes out with a red face. I'm thinking, okay, what's wrong? Now, my colleague was female, well, still is female. And she told me, I don't want you touching me, get out. And that's like, okay, that's pretty aggressive because over here, people are very differential towards their doctors, right? So, I said, that's fine. We got a junior resident who was also a female to go in and see her. 5 seconds later, out she comes, angry. Patient told her, get the hell out. I thought, okay, what's going on? Now I'm going to have to get involved. So I went in, knocked, and I said, excuse me, my dear, everything okay? She said, doctor, do not send a female to see me again. All I want is a male doctor. I've had enough of female doctors. I thought, okay, there's definitely a story here. You know, she must have had a, you know, a negative experience with somebody. This is why. So, but that is not a particularly rare event here. So, you know, it all depends on the background. I mean, traditionally, you'd imagine, you know, it would be a female doctor's market here. And indeed, in terms of the local residencies in OBGYN, at least, 60 to 70% are female trainees. But at the sort of at the end results phase, patients are, you know, depending on the background, we're talking at least a 50-50 split. Some don't mind who sees them as long as it's, you know, a professional. The more traditional might want to go to a female, either because they prefer a female or because, you know, there is family pressure. But it's certainly not the days as it used to be where, you know, 70% would refuse to see a male and you'd be sitting there sort of trying to do your job and not being allowed to do it. So, you know, it is interesting to hear when this happens, especially in America or in the UK, for example, because the impression we've always had is that, oh, it's not an issue over there. You know what I mean? So it is interesting to hear that it still happens there.
How about shifting gears here? What about, women who are having high sugars during pregnancy and things like that? How are you managing that there? Is it hard to make nutritional changes and recommendations?
Well, I'll tell you how everyone else does it and then how I do it. Now, how everyone else does it is the traditional route. So, you know, they'll come along, we'll do their glucose challenge test at 24, 28 weeks. It's high. You'll do your glucose tolerance, diabetes. Next step is referral to the nutritionists who will usually advise the time-honored high-carb diet, calorie counting, low-fat, you know, give them their schedule in terms of how often to eat and how many snacks. Surprise, surprise, a huge ton of them end up needing insulin because the blood sugars are not stable enough, right? So what I tended to do is I don't send them to anybody. You know, any patient that comes to me who ends up with gestational diabetes, I will advise them to go the low carb route. So I'll usually tell them, you know, I don't want you, you know, eating this usual amounts of rice and bread and refined stuff and fruit and all the rest of it. I'll explain, you know, why I'm saying this. I'll usually tell them, okay, please up your protein, up your fat in case you're worried you're going to be hungry. We'll watch your blood sugars, send me your blood sugar readings by phone, you know, by message every 3 to 4 days. And provided the blood sugar readings are within the you know, the acceptable ranges, I just keep it like that. And, you know, admittedly, I've had a very small cohort so far that I've been managing myself, but I haven't had anybody who needed insulin. I haven't had anybody who needed metformin or glyburide or any extra help, simply because, you know, gestational diabetes is a condition, as you know, of insulin resistance and glucose intolerance. So why on earth would I give them glucose and then wonder why their blood sugar was not controlled? And again, I don't understand this cognitive dissonance people have when it comes to this problem, you know? Send them to the nutritionist who's going to tell them to eat carbs. Well, what do you think was going to happen? It's not the fat that caused them to have an abnormal GTT.
And that's the same thing we deal with our diabetics here in the States. The same thing is they'll say, you have to, you know, have a patient, she comes to me, her sugars are in the 300 range. They never once checked an insulin level on her to see if she's making insulin. And they're like, you need 80 grams of carbs with each meal. I was like, why? Why exactly do you need that? Right. So, you know, when you see these things, you think, wow, it's just remarkable and amazing. It's like they've never seen a continuous glucose monitor in their life or something, or even checking finger sticks. And, you know, looking at it from a different paradigm. And I get it because we were trained in a certain way and we think that way. And it took Jason Fung and a couple other docs to really say, Brian, look at it from the other side. It's not all about the sugars, it's why the sugars are there in the first place, you know, and understanding metabolic disease. And that's what's so great. And it's so encouraging to us, Tro, to have people in different areas of medicine who are seeing the same thing from their perspective and say, how do we put these pieces of the puzzle together and treat our patients the best they can, right? Because they're not in a vacuum, because problems you're seeing are because of metabolic disease. Problems I'm seeing and Tro are seeing is because of metabolic disease. So that's really that's what we have to tackle as the underlying cause, as Ben Bickman's book, you know, eloquently talks about, of saying, hey, look, we have to look at this and say elevated insulin and insulin resistance is a huge, huge problem across the board. Anything we're seeing this.
No, I totally agree. And I think it's probably, you know, one thing I should probably point out here, that there is a lot of, you know, American influence on this side. So I can tell you now, whatever issues you guys are having, we are having here. whether it's obesity levels, metabolic disease, the wrong advice, quote unquote. What America does today comes over here tomorrow. So when America starts to do it right, we will probably do it right maybe a week later, kind of thing. But yeah, no, I mean, I find it very frustrating just because, if you're talking about other doctors, the second year of med school, biochemistry should have told you that what you believe now is wrong. Nobody wants to think about what they learned, right? If it's a nutritional point of view, now, I have my own quibbles with how they're educated. When you think about it, the nutritionist should be the most rigorous, the most intellectual of all of us. Getting into nutrition school should be even harder than getting into med school. The amount of information, the amount of research that's been done, those people should be the experts, right? So when you find experts, quote unquote, who are telling diabetics, as you said, 80 grams of sugar per meal. I mean, I've seen a distant relative of mine diagnosed with diabetes at 5 years old, right? Professor of endocrinology telling her parents, no, she needs carbs to grow. And you're thinking, she needs carbs to grow. This poor kid is going to have renal failure in 20 years with the way that you're carrying on with her. She cannot live her life normally. She needs to understand this. And at 5 years old, you can program her to live a normal, healthy life, because she's not going to know what the other normal looks like. You know what I mean? But again, who am I, the humble gynecologist, to speak when the professor of endocrinology is speaking? What do I know?
Yeah, it's a hard thing. We all, being a prophet in your own land, right? I mean, sometimes when you say it and people go, yeah, I know this guy, I'm not going to listen. And so, it's funny. It's really a true statement. And, we're just so excited about what you're doing. And just knowing around the world, people are looking at the problem saying, wait, this isn't working. And at some point, kind of like we talked about beforehand, you tried all these different diets and you go, okay, let me see what works for me the best. And then we keep changing our tact. We don't just say, okay, just keep doing that diet that didn't work for you. You lost weight and gained it all back. Okay, let's keep doing that over and over again, right? Instead of changing tacts. And that's a sign of a good doctor who says, okay, this isn't working. We got to change tact. And that's what Tro and I are learning too. Some people, Tro, I'm going to have a guy on the podcast that's going to blow your brains out, man. I mean, just like his story and what he does is exactly the opposite of what we're saying. And he's having success. I'm like, I can't figure him out. But having that and being open to it and say, what is he doing that's working? But what he does do, even though he's eating a lot of fruits and vegetables and no meat, he has a huge amount of muscle mass. But the thing he doesn't do is eat processed foods and seed oils, right? So maybe we could all agree on that and say, okay, let's cut those things out as much as possible. Now, going back to what you said, the problem is the nutritionists and dietitians are all trained by industry, as are doctors. So then we're going to have a biased view of saying, oh, it's okay, eat carbs and just exercise more, right? Drink your soda and then just exercise more. And we've lost track of what we're supposed to be doing. And we're biased no matter what.
Yeah, I agree.
No,
not only are we biased, not only are we biased, but I feel like most physicians and most residents and medical students, they're not inspired to learn, and we're so burnt out. We're overworked. We've lost our questioning mentality. We've lost our ability to question our beliefs. We've lost our ability to be interested in actually learning. And I think that the entire system is to blame, the medical education system and the pressures and financial incentives we've placed, the industry is placed, the way that insurance companies basically pay doctors to see patients more quickly. I think all of this needs to be just transformed so that we get re-inspired to actually help people instead of just get through them as quickly as we can to see the next patient.
Well, and maybe, Tro, that was my advantage, right? Dr. Tarek, we weren't good memorizers, so we had to understand the concepts. We had to understand how it worked rather than just memorizing the outcome, right? So I think when you have to think that way and you're not a great memorizer, you're not the smartest guy and you have to work really hard, I think you understand better because you have to understand the concept. I have to understand the concept. I just can't memorize an outcome. So I think when we think that way, now we're saying memorize all this stuff, and it's so hard, Tro, memorizing all the muscle insertions and origins and all that stuff that we had to remember. It's just so much information that you just have to memorize. You have to be good at that. And so that's it. And I think people who worked hard got through med school, right? And so those hard workers, because we're that nature, then we work our lives away because we think we have to work 14-hour days to be a good doctor, instead of saying, okay, how do I have a little bit of a life on the outside? And I think that's something that medicine's starting to learn, the importance of that. Because
or how do I actually reach people? You know,
how do you reach people and connect with people?
How do I actually reach somebody, grab them, change their life, have them change their families' lives, so we can just get rid of this cluster mess that is the obesity, diabetes, hypertension, heart disease, cancer epidemics, right? It's not going to happen by churning people, you know, one over the other in 7 minutes. Like, you have to sit down and affect somebody's life. And how do you be your brother's keeper? Sorry to bring back to religion. How do you be your, you know, how do we actually affect these people's lives, takes responsibility for their health?
Well, part of it too is you teach mom, and she's going to teach the kids. Right? She's going to raise them in a way that you say, okay, you're not going to eat terrible food all the time. I learned this from my doctor who is delivering you, right? So I think that's where you have the power there, is to change the course of a life. Because so many times women have gestational diabetes and then they don't make any recommendations. They just go, okay, you're fine now. You delivered the baby, and now they go back to their old lifestyle and they're going to get worse. They're going to end up with diabetes. We know that as a vast majority of the cases. So I think these are things we really have to look at. So Doc, thanks for staying with us this long. It's so great to have you. And I would love to have you on another podcast that I'm going to do and just talk to you about life and what's important, because you know, I think you have a good grasp of that, and I love it. So how do people get in touch with you if they want to track you down?
Well, as Tro alluded to earlier, I'm rabble-rousing on Twitter. So Dr. Tarek Arab on Twitter. Same thing on Instagram. Haven't set up my own website yet because I don't know where life is going to take me over the next few months. So I thought, you know, before settling in that, in any one place, let me just see where things are going. But essentially, that's where you can find me. If anyone's in my part of the world, I consult at First Clinics. But that's pretty much where I'm at.
Yeah, well, thanks for spending time with us. It's greatly appreciated, and you kind of got me fired up today. Tro, you want to close this, man, with your words of wisdom?
Yeah, no. I love the curiosity, the ability to consider contrarian viewpoints, the ability to think about things differently and consider other groups of thought, but still be grounded in evidence and critical thinking. I mean, this is, guys, if you're a medical student or a resident, this is a quality of a good doctor. Thank you, Dr. Tarek Arab. We really appreciate it. Thank you for everything that you're doing. And it's just an absolute pleasure.
Thank you very much. And just to keep a promise to my sister, she just wanted me to convey to you, she loves your wife's various low carb mixes. She's in Westchester, so she's going to be a very loyal customer for the next couple of years at least.
Yeah, man, my wife's all excited too, I'll tell you, Tro. She's like, I'm waiting for my pizza recipe and all this stuff to get here. So yeah, I guess we're going to keep you guys pretty busy. Yeah.
Listen, she's you know, I'm going to take a second to say this because my wife is just such an amazing person. It's been, you know, all these things that she's putting out there, you know, it is a commercial enterprise. But it's been all the things I needed in my journey, she's just now putting in a bag, right? And her heart is just so large. I mean, she has not taken 1 cent of profit yet. She's donated to several hospitals during the COVID epidemic. She literally baked cookies and just donated them. A local hospital in the Yale system, Greenwich, White Plains Hospital, the physical therapy departments, clinics. And, you know, she just donated also to Armenia and Artsakh. What's going on there is very terrible. And she just, you know, it's like people say, like, you have this conflict, Tro, you know, your wife, she's in the commercial business, she's the evil food company, but she's my inspiration, and she has, she's a humanitarian first, has not taken 1 cent of profit. So she's my everything.
Oh, so, man, we'll close on that.
All right, guys, have a good one. Thank you so much.
You too. Take care. Have a good one.
All right, Doc, have a great weekend. Thank you so much for joining us.
Thank you.